Hello, everyone. My name is Tram Lam. On behalf of the NCI and my fellow co-chairs, Dr. Joanne Elena and Dr. Shobha Srinivasan, welcome to day one of the Cancer Epidemiology in Hispanic Population virtual workshop. We are so pleased by the high level of interest on this topic, with more than 500 individuals from diverse backgrounds who have registered to participate. This meeting reflects just the ongoing conversation and effort that NCI has commenced in 2015 with the think tank on understudied population and cancer epidemiologic research. The Cancer Epidemiology in Hispanic Population meeting coincides with the start of the Latin and Hispanic Heritage Month. We will celebrate the history and culture and recognize the achievements and contribution of Hispanic Americans to the United States. We are so excited and look forward to spending 3 days with you, engaging and discussing science, the challenges and opportunities for cancer epidemiology research in Latino population and future directions. The planning and organizing of a virtual meeting of this scope was quite an undertaking. I am so very grateful to work with such a collaborative team to put together this program for you. Joanne, Shobha, and I would like to acknowledge our colleagues for their hard work and dedication. Thank you to our speakers, moderators, and facilitators. The links to the agenda as well as the full bios of our guests have been posted in the chat box. It is now my honor to introduce our keynote speakers, Dr. Bob Coyle and Dr. Eliseo Perez-Stable, for the opening remarks. Dr. Coyle has been an incredible leader and the director of the Division of Cancer Control and Population Sciences at the NCI since 2003. Dr. Perez-Stable is the director of the National Institute on Minority Health and Health Disparities. Their collective support of this meeting and the overarching efforts in addressing health disparities and advancing health equity for all is inspiring. Welcome to Bob and Eliseo. Bob.
Thanks, Tram. Just had to corral a out-of-control puppy that was trying to introduce himself on the screen here. Yeah, thanks to all the planners and organizers. This has been a long time coming, and I think we started planning this when I was a child, because it seems like there's so many fits and starts and delays with COVID and other things. And also thanks to colleagues from other parts of the NIMH. You'll hear from our good colleague Eliseo, National Institute on Aging, NHLBI, and others. And so it's great to get folks together. I see this meeting as a complement to an important ongoing meeting in San Antonio that a lot of us have participated in the last couple of times that Amelie and Ed Trapito put together. And so thanks for that. That's also been really important to overall convening folks, sharing the science, and keeping this all up to date on work in progress as well. I should mention too that this will be one of the last kind of conference introductions I'll be doing over the next month, because I'll be stepping down as director of the Division of Cancer Control and Population Sciences. And in not too short a time, on October 11th, my successor, Dr. Katrina Goddard, who many of you know, will be starting. She'll be joining us from Kaiser Permanente Northwest. She's tuning into this meeting to learn about all the area and the great work that you're all doing, and also a lot of the issues and unresolved issues that'll be discussed on the agenda. The complexities that we're still fully aware of at NCI, and we've discussed with many of you, whether it's in surveillance and assessment and accurate estimates of incidence mortality, which will be touched on at this meeting. Also other methodological issues in terms of recruitment and retention, methodological issues in terms of exposure assessment, and then how all these relate to ongoing policy issues in HHS and at a broader level in terms of healthcare access and delivery. Epidemiological research is kind of the foundational discovery arm of population science. And so it's really the foundation that informs all the other areas. And it really generates the evidence in terms of risk and exposure and the interaction with those factors that then feeds into so many other fields and disciplines that are represented at this meeting. And so I think, without good epidemiology, we're really stuck. It's really a prerequisite field, an area of research. And the meetings and the discussions, the topics of this meeting aren't strictly limited to just only epidemiology, but that's really the focus. And we felt that that was appropriate because of the open research questions, and also the need to make sure that you hold our feet to the fire at NCI and NIH in ensuring that all of our research infrastructure in cancer is being fully utilized and exploited to answer research questions relevant to Latino populations. We need to make sure that there's adequate representation across all forms of research. And we're really pleased that in the last couple of years, we've made some significant progress on that. We've funded new cohorts focused on Hispanic populations, on survivorship as a part of that RFA. We've funded a number of new projects. And so the portfolio is growing. And also it's growing in a way that's not just, in a sense, adding a few Hispanic participants to larger studies. It's focused research that really has focused hypotheses that are guided by the evidence specifically about Hispanic Latino populations. And so that's what's really kind of changed, is that the breadth of our investment and also the expansion of capacity to answer research questions that have been around for decades is really growing. I'm really excited too that this year, finally, and as a part of our 50th anniversary of the National Cancer Act, we achieved 50% population coverage of the SEER program. That was really important too, and this is something we've been aspiring to for many years, is that is really increasing the quantity, the breadth, and the quality of surveillance data to inform research on Latino populations. We know that what was in SEER was being used by a lot of researchers, but didn't fully represent the geographic spread of the subpopulation across the US, and also enable research on subpopulations. We've also partnered with NMHD, and you'll hear more about this from others at the meeting, on a number of initiatives as well. And then finally, I wanted to note that we've also diversified our program director staff at NCI, especially in our division of cancer control population sciences, so to increase the diversity of representation in our program director workforce, which I think that was also overdue at NCI as well. So I think all these efforts really are focused on, identifying the gaps, identifying where the research needs are. We've had a lot of discussions about those at other meetings the last several years. And finally, a lot of action being taken to address this and make progress. So I'm really excited that as Dr. Goddard comes in October as the new director of population science at NCI, she's going to be better equipped to lead the effort to address all of your research questions and enable you to submit applications that are highly competitive, because you've got the sample sizes, you've got the infrastructure, you've got the resources that are the prerequisites to do the research that we need to get done. So thanks again to all the organizers. Thanks to all of you who I may not see in the next few weeks, for all your support and research and collaborations, your efforts in this area, your collegiality. I'll be on the payroll until the end of the calendar year. So December 31st is my last day. So there'll be overlap between myself and Katrina. And I also want to thank Eliseo, who chaired the search committee that recruited and identified our new division director, Katrina Goddard. So it all comes full circle, because all of our long-term relationships, Eliseo being a former grantee of this division, and all the work we've done together over the years on the networks and the consortia and Redes and all the things that many of you have been involved with. It's been really nice. And as a Canary Islander descendant myself, and proud of that, some of you out there who I referred to as cousins, fellow Canary Islanders, shout out to all of you. So thanks very much, everybody. And I'll turn things over to a terrific colleague. And everybody on this meeting needs to know the impact it has had at NIH to have someone like Eliseo sitting at the table among the institute directors at NIH, at this agency. And all the things he does behind the scenes, many of you don't know, but how he represents us with the department, with the White House, with members of Congress. He is a terrific representative and spokesperson for all of you, and he's been having a great impact. And I just want to congratulate you, Eliseo. It's so great to have you here. I feel better retiring having you at the NIH. So thanks, amigo. You've been terrific, and I'll turn things over to you.
Well, Bob, thank you. You leave me embarrassed, but I do greatly appreciate that comment. And I would add that you were part of the search committee that found me. And if it wasn't for you, I'm not sure I would be here. So I think the gratitude is mutual. You've heard a wonderful intro about the framework and different aspects of Latino, Hispanic cancer epidemiology and research. I'm going to get us started with a few comments. Some of you who were at the February 2020 Latino Cancer Science Conference that Amelie hosted in San Antonio will be familiar with this. I'm going to share my screen. I'll try to be brief in a few minutes, and just to put some topics on the table. So let me switch to slide show, and I think everybody see these okay? All right, so I should have said, first of all, good morning for many of you, and good afternoon for those of us here on the East Coast. So you heard the background. I'm just gonna go through this. So these are 3 points that I keep hearing. I've been hearing these since I started doing this work over 30 years ago. So Latinos are all different. We can't possibly compare Cubans and Puerto Ricans or Salvadorians and Guatemalans or Colombians and Venezuelans because everyone's different. And in my retort to that is, well, that's a strategy of the dominant group, divide and conquer. So we got to group ourselves together and then look at differences later. And so disaggregation is a mantra that many of especially the Asian Americans have taken on, but Latinos as well. And I agree with it, but I think we need to make sure that we don't abandon this context of a larger size. There are 62 million Latinos now, per the 2020 census in the United States. They're the largest racial ethnic group in the state of California, the largest state in the Union, as well as New Mexico and Puerto Rico, which is not a state, as we know. Second point here is the mortality paradox will disappear with time. Everyone believes, a lot of people believe this, a lot of scientists believe this. They say, well, Latinos will just get spoiled. They come in healthier because they're immigrants, and therefore they have better habits. They'll get spoiled, they get acculturated, they'll get overweight, whatever, eat poorly, not exercise, and end up with the same death rate. So I'll mention this. And then linked to this is the acculturation is bad for your health. And we'll end the paradox. Will be the mechanism, one of the mechanisms by which that will happen. So we know about the epidemiologic paradox coined by Coco Marquides in 1986 that I'm aware of around issues around infant mortality at the border. Outcomes are better than expected based on the known or standard predictive risk factors. And these are usually based on socioeconomic status. Latinos have a flatter gradient of socioeconomic status relationship to health than other groups that have been evaluated. Now, could be a measurement issue, could be a missing data, but it's been fairly consistent in the areas where we have had the data to look at, primarily around infant and maternal health, although in some conditions as well. There's a 3-year life expectancy advantage. Granted, that has been severely dented by COVID pandemic, at least based on preliminary reports of 2020 life expectancy and mortality. But we will see how that sorts itself out over the next few years. And then the issue that less privileged socioeconomic status doesn't always translate to worse outcomes breaks a public health paradigm. And therefore, most people, when they see this, ignore it rather than try to understand it or find mechanisms to explain it. We don't have a lot of detail on comparisons of Latino national origin or national heritage groups, socioeconomic status. This was a fairly good snapshot done by the CDC, now published 6 years ago, and data from 2013. And you can clearly see that, for example, Cuban Americans are better off in terms of education and percent below poverty than, let's say, Mexicans or definitely Central Americans, although still considerably higher, in fact, more than double that for white Americans. And you, over here roughly are the proportions of these national origin groups, with Mexicans dominating the total statistics because of sample size. I have, since I was an assistant professor, thought that Latinos are more similar than different. I'm of Cuban background myself, and worked all of my career in California with mostly Central American and Mexican American Latinos, but really people from all over Latin America. And I would say there are more similarities than differences despite all these different national origins. And I would still say that's true. I think a mix of common cultural themes unify, despite the multitude of groups that exist within Latin America. There's a central role of the Spanish language in most of the Americas that are part of Latin America. There is this common theme of racial mixture. There's 500 years of European colonialists and immigrants. There is indigenous people who were not marginalized totally or wiped out, as happened in most of North America, north of the Rio Bravo. And then there's the forced African migration of slavery, which actually about 60% of Africans brought to the Americas did not come to North America. They went to the Caribbean, Brazil, and the rest of Latin America. We even have Asian enclaves of immigrants. Havana had a large Chinatown. There are many Asians in coastal parts of South America, particularly in Peru, and a large Japanese community in Brazil. There's also the shared heritage of the Catholic Church influence. Keep in mind, as we think about the role of politics in health, that Argentina, Uruguay, and now Mexico and Cuba and Puerto Rico are the only countries in Latin America where abortion is legal, relatively speaking to the other parts of Western Europe or the United States. There's this shared political and economic dominance relationship with the United States for the past 130 years. This is not something that people living in the United States who are North American think about very much, but it is an important common theme in all of Latin America. What the United States has represented from supporting military dictatorships to economic domination to the banana republic concept. And these all have evolved. I'm not saying any of these are necessarily current, but these all have an influence on this relationship of this community. And on the global spectrum, Latin America is middle income. So we're not too poor to be looked at for everyone to help us, nor do we have any money. And this makes it sometimes tough. Some quick causes of death, again, from around 2013, comparison for cancer, heart disease, stroke, injuries, and diabetes. We can see for cancer that Puerto Ricans tend to have the highest, although all of them are lower than whites, and similarly for others. And I'll go through just the cancer ones. This is a breakdown by national origin of age-adjusted mortality rates. Cubans had the highest lung cancer, parallels to higher smoking rates, but still, compared to white Americans, it's lower. And the same is true for prostate, colon. Liver is higher among Latinos in general, as you probably all well know. So why does the paradox exist? The most endorsed theory is this healthy immigrant effect. People who pick up and leave their country voluntarily do so because they're looking for a better opportunity. They're often not poor, but they have enough personal resources to be able to make this trip and start over. And this is not unique to the Latino immigrations to the US. This was actually described by anthropologists over 100 years ago about the European migration to the United States and also other parts of the Americas. Keep in mind that almost 2/3 of all Latinos in the US today are born in the United States. So we are no longer an immigrant dominant community, unlike, let's say, Asians that remain that way. There was a popular hypothesis called the salmon hypothesis about Latinos returning home to die and therefore deaths not being recorded. This is still some debate among demographers, but I think there is no good data to support this. Some issues around misclassification, particularly in the medical or healthcare setting. But I think from a public health perspective, the census and CDC and the National Center for Health Statistics have really figured this one out. Sorry about that. And then Latinos in general have been misclassified as whites in many clinical settings, or not, nobody's asking. Finally, I just share this slide from a project I was privileged to collaborate with. This is with the NCI intramural program in Division of Cancer Epidemiology and Genetics that compared more adjusted statistical mortality rates across a bunch of countries in Latin America and the United States by race, ethnic groups. Notice here where US Latinos were in 2001. Actually, I don't see them here in the, they're here in the 2015 estimates. So pretty low. And mostly a lot of Latin American countries are similarly low. These are overall adjusted mortality rates dominated by cardiovascular disease, but cancer is often, if not most frequently, the second most common cause of death. In acculturation, I think that the belief that Latinos acculturate get bad habits and get more chronic disease and lose their mortality advantage has been accepted without data. I would say the challenge is you have to be empirical, and I think the data supports evidence that women do, among women, Latina women, they tend to drink more alcohol and smoke more with measures of acculturation, primarily based on language. They need to account for other social determinants of health, particularly socioeconomic status, and the idea that people don't acculturate in a linear way, or that you may have influence by socioeconomic status, reflects this model of segmented assimilation. So you have downward mobility of professionals who come to the United States and who are not able to work in their profession in this country. And similarly, you have individuals who have upward mobility because of opportunity for education and potentially for economic opportunities in business. And this whole issue of smoking we've used in part, without going into details, to try and see how this may change by acculturation. This is the idea of the segmented acculturation model, that it isn't linear, but that these factors, also healthcare access, will influence the outcomes that one develops. And although cancer is hard to study in this context because it's, one, so infrequent, and two, takes a long time to develop cancer, there are empiric data to support that this is not so linear in diabetes and in hypertension and potentially other chronic disease. Now, this is, I think, my last slide with data. This is work from Dr. Pinedo, who I think is presenting in this meeting. And it, again, it shows foreign-born Latinos' rates of cancer by the most common causes of cancer here: breast, lung, colon, prostate, and liver, compared to US-born Latino, African Americans, and whites. And yes, for all these cancer rates, US-born Latinos are higher than their foreign-born counterparts, but they're still lower, for the most part, than their white counterparts, except in liver cancer, where they start off higher and actually go much higher. And that is in and of itself of interest, both epidemiologically and mechanistically. I think that's it. This is just my standard NMHD slide about the kinds of things that I like to see move. And I'll stop for the sake of time, and I look forward to all the presentations that will happen, as many as I can watch in the next couple of days. Thank you.
Thank you, Bob and Eliseo. Those are wonderful remarks.